Good evening, everyone, and welcome everybody to our Heart Matters presentation. I want to thank everybody for joining tonight and spending the time with us tonight. And Marty, if you could show the slides. Okay, yes, thank you. I wanted to make sure we're let you guys know we're featuring experts from Adventist HealthCare's Cardiac Associates practice from Adventist HealthCare. Next. I wanted to let everybody know that our CME credit tonight comes from White Oak Medical Center, and it will award people 1 credit. And we'll have some reminders around taking the survey and things. So next slide. We have no disclosures tonight, so that's good news. Next slide. Again, at the conclusion of our activity, our participants will be able to look at and be able to speak to our 3 objectives. Again, our first objective really to describe to their patients the screening, detection, evaluation, and treatment of patients with high cholesterol using lipoprotein A. The second one, explain to their patients how cardiac imaging helps to assess the risk of heart attack and stroke. And our third objective, really to explain how coronary calcium scan is used to support and guide treatment decisions in patients with heart disease and other heart-related conditions. Great, and we also have a credit, a ANCC continuing education credit as well. Just as a reminder, everybody needs to, attend the entire presentation and complete an evaluation at the end of the presentation. And again, this is 1 contact hour. Great. And I am Barbara Courtney. I serve as the Associate Vice President of our Heart and Vascular Service line at Adventist HealthCare. I'm really pleased to be here. And I am here to introduce our 2 very wonderful speakers tonight, Dr. Bryan White and Dr. Guy Weigold. I'd like to start with Dr. Bryan White first. Dr. White is a board-certified cardiologist with Adventist HealthCare Cardiac Associates. He grew up locally outside of Leesburg, Virginia, and graduated from Virginia Tech with a BS in biochemistry. Go Hokies! He obtained his medical degree from the Uniformed Services University of the Health Sciences in Bethesda, Maryland. He completed his internal medicine residency at Wright State University and then his cardiovascular medicine fellowship at The Ohio State University. He recently joined the practice after retiring from the United States Air Force at the rank of colonel. During his career, he served both as the chief atrial fibrillation cardiologist and the chief cardiologist for the Defense Health Agency. He is currently board certified in internal medicine, cardiovascular medicine, vascular medicine, and nuclear cardiology, as well as being RPVI certified. He is non-invasive cardiologist whose interests are non-invasive imaging, preventive cardiology, vascular medicines, and sports cardiology. Our next speaker, Dr. Guy Weigold, is a board certified in cardiovascular disease and cardiovascular CT. Dr. Weigold received his medical degree from the University of Minnesota and completed his internship and residency at Northwestern Memorial Hospital in Lakeside Veterans Administration Medical Center of Northwestern University. After residency, he completed a cardiovascular disease fellowship at Washington Hospital Center in Washington, D.C. Prior to joining Adventist HealthCare, Dr. Weigold was the medical director of the cardiovascular CT, as well as an attending physician in the cardiology division at MedStar Washington Hospital Center and MedStar Heart and Vascular Institute in Washington, D.C. During his time at MedStar Washington Hospital Center, he was also a preceptor for Georgetown University Medical School of Medicine students and teaching and attending on the cardiology, cardiovascular ICU, and cardiology consult services. Dr. Weigold has published in several different publications, including abstracts, books, and peer-reviewed articles. He has also presented on a variety of topics at invited lectures and scientific presentations and has completed several research activities. Dr. Weigold is a member of various professional associations, including the American College of Cardiology, the American Heart Association, and the Society of Cardiovascular CT. We thank you for joining us, and I'd like to welcome Dr. White to begin our presentation of the evening. Thank you.
All right, perfect. Can you hear me now? Okay. It's an honor and pleasure. And I do join you from the Air Force. I appreciated Barb's introduction. But as a little bit of a correction, I was a chief Air Force cardiologist, not a chief atrial fibrillation cardiologist. But given today's real world events, maybe most in the Air Force are experiencing atrial fibrillation. I don't know. But with that, let me just hit this button here. It's an honor and pleasure to be here and to be with my esteemed colleague, Dr. Weigold. I look forward to hearing to his component. Um, what I, Here we go. Thank you. And then what I wanted to say is that, it's an honor and pleasure to be here. Cardiovascular disease has a tremendous incidence and prevalence in the United States. And what you see here on this diagram is that in the very young, you may see a prevalence less than 1%. But overall, you can see as we get older, cardiovascular disease is going to be something that is going to progress significantly as we get older. Things that we already know: 6 to 7% in our 40s and 50s, 20% for males in the 60s and 70s, and 1 out of 3 in males over the age of 80. But what was just released in the Washington Post yesterday was actually that cardiovascular disease remains, and I'm quoting, cardiovascular disease remains the leading cause of death in the United States, accounting for over 900,000 deaths in 2022, and released from the American Heart Association statistics. And then in 2022, heart disease and stroke killed more people than all forms of cancer and accidental deaths. And that coronary heart disease was the leading cause of cardiovascular disease, followed by stroke and other forms. And that 1 out of 3 deaths in the United States is related to cardiovascular disease overall, and 1 out of 5 deaths in younger patients ages 25 to 64. And that more people died from cardiovascular disease in 2022 than they did the year before. Um, so again, we all understand the significance of cardiovascular disease. And as we look across, the United States, the prevalence is going to grow through different states. Briefly, if you're beige, you're better than you're green. If you're green, you're better than you are blue. And while you may be from the state of Virginia or Maryland, and relatively that is better than some of the areas around us, a lot of areas around us, I have a high prevalence of heart disease. And please note that actually there's a shortage of physicians across the country, and that 50% of patients nationwide live in counties that do not have a cardiologist. And while the state of Maryland, every county has a cardiologist, and the state of Virginia, about 40% of the counties do not have a cardiologist. And then as you look at cardiovascular disease worldwide, again, more than 500 million people worldwide suffer from atherosclerotic cardiovascular disease, resulting in over 20 million deaths annually. And that if you go back to the United States, that when you look at the totality of the financial implications, it's in the hundreds of billions per year, probably 250 billion, and that 25% of deaths are directly attributed to elevated LDL, and that 75% of patients or persons will have an LDL greater than 70, and 25% will have an LDL greater than 130. So I think that we all understand the significant impact that cardiovascular disease has, specifically what risks that elevated or hyperlipoproteinemia will have, or high cholesterol have. When you look at the American College of Cardiology, they'll put a focus on a team-based approach. And one of the things I find interesting is that we'll get, as providers, reviews every month, and will talk to us about how well we included our patients in decision making. And I think that that's step number one, that we have to talk to our patients and focus in involving our patients in decision making. And that we have to involve our patients in non-pharmacologic therapies, such as eating well, exercising, giving them that talk about counting their fats or saturated fats, unsaturated fats, how much exercise per day are they doing? less than 13 grams of saturated fats, avoiding trans fats altogether. And we're going to show a slide that less than 200 milligrams of cholesterol, knowing that one egg, which may cost $5 to buy, contains 150 milligrams of cholesterol. So really with two eggs, you really have reached your daily dietary allowance of cholesterol. Now, there are some other therapies as far as pharmacologic therapies. And this slide, respectfully, I still need to kind of continue to evolve because, I'm going to talk to it a little bit more. But the American Association of Clinical Endocrinology just released their update here in 2025 to the 2017 guidance. And so some things are in and some things are out. And then, although e-cigarettes may increase the likelihood of quitting smoking, their safety has not been determined and they should not be advocated for. And one thing I throw on there is that we want to make sure that we're not advocating for the use of marijuana, which could have several negative cardiovascular effects. But when you look at this model here, you have the patient on the left and you have the providers on the right. And you have to, and especially in Montgomery County in this region, we are very lucky and blessed to be as diverse. And we, will have people who work for the FDA or NIH, or we'll have people that have immigrated to this country in the last weeks or months or years. So there can be a wide heterogeneity in people's health literacy or their social support or their finances, their socioeconomic status. And so, as we have those patient factors, we have to understand what are the things that we can bring to the table and then lead to that shared decision making. And that's what I really try to do when I'm with the patient is lead to shared decision making. And if you look at some of the newer calculators, they will actually incorporate, the area code in which the patient lives to help determine those social determinants of health. So again, what are the things that are good? What are the things that are bad? It's one of those where, obviously legumes, the vegetables, the whole grains, the leaf proteins, those things are going to be better. And your unsaturated fats are going to be better, like your olive oils, versus trans fats, which would be a McDonald's type of food you want to avoid absolutely. And then again, you want to minimize your salt intake, your saturated fat, your processed meats, and your simple carbohydrates and alcohol intake. So again, how do I approach things with my patients? And it's after the counseling, it's one of those where I've done the intake and I've done the education on the non-pharmacologic interventions. And then one of the things that when you look at both the AHA, or not just both, but you look at the AHA or the ACC or the American Association of Clinical Endocrinology, they're going to put a focus on, prediction models, whether it be the AHA Prevent or the atherosclerotic, cardiovascular disease risk calculator, but some calculated estimation of what a patient's risk is going to be. And that's where they really put the focus on. And recently they published what their C statistic is for these different, and roughly they vary from about 0.7 to about 0.84. The closer to the one, the better. And under 0.5, it's kind of worthless. But there's a huge focus on starting there with your patients. So I try to determine that, but also I know that Dr. Weigold is going to talk about coronary artery calcium. I'm going to talk a little bit more about where we are today with lipoprotein A and where we're going in the future. And then again, some of the other things that we can do with lipid metabolism and lipid evaluation. Now, just briefly, I definitely use the calculators. And one things I try to share with my patients is going to be this. I like to look at your total cholesterol. I like to look at your HDL. I like to look at your triglycerides. I like to look at your hemoglobin A1C. And I like to look at your LDL. So if you look at all the primary prevention trials and the secondary prevention trials, which we will in a second, it's one of those where there's a linear proportionality of the reduction in LDL to the reduction in ischemic heart disease events when it comes to statins. But as I look at a person's risk profile, sometimes I'll have a patient that have an LDL of 130, but they'll have a blood pressure of 100/60. They'll have an HDL of 80. They'll run 10 miles every day. And what I kind of tell people is if we did lipoprotein fractionation on these patients, you would see that they would have an average particle size that's larger, softer, less atherogenic, less inflammatory, and less a smaller number of small LDL particles. I always give patients that analogy. The small bad LDL, really bad LDL, that small, dense, more pro-inflammatory, more pro-traumatic, atherosclerotic, that baseball-like versus the pill-like. I used to have a slide like that, but that's when I'm talking to patients about their cholesterol profile. The patients with the high triglyceride, low HDL, high LDL, high VLDL, and we can't forget that non-HDL, they're going to have the baseballs traumatizing coronaries, causing coronary disease. And patients with high HDL, low triglycerides, they're going to have a little bit of a lower risk. So that's how I evaluate things as far as when I'm having those discussions. So obviously, we understand that with primary prevention, those are people that do not have known symptomatic coronary disease or known coronary disease. And how do we define that? Patient has had acute coronary syndrome or a patient with asymptomatic coronary disease, but a narrowing of 50% or greater. Now, with that, I roughly tell patients that as you get older, like 60 years old, the likelihood of having some degree of coronary calcification is roughly your age. But that doesn't mean coronary atherosclerosis means that you have the disease as a result of coronary atherosclerosis. But there are some coronary disease syndromes that may not require a high degree of coronary atherosclerosis. But that's primary versus secondary. We talked a little bit about pool cold heart equations, risk enhancers, and then CAC. And again, I know Dr. Weigold is going to talk about that later. So, what are some of those, risk enhancers? Some of those things that you want to be taking in your clinical histories, right? Do you have a family history of heart disease? Did dad or brother have heart disease before age 55, or did mom or sister have heart disease before age 65? And I'm sorry, I think I must have hit a button there. So use your error. Do they have one of the things I would say about the AACE is they kind of both the AACE and ACC will kind of say not really that 70 is normal, but above 70 is when you start adjudicating risk. In the AACE, they'll say that if your LDL is greater than 130, that's a hyperlipidemia. Here, in this ACC representation, it's greater than 160. But again, if you have and remembering that in the ACC model, if your LDL is greater than 190, you automatically have a 10-year risk greater than 20%. You're going to be put on high intensity statins. So here, if you have a primary hypercholesterolemia greater than 160 or a non-HDL, just remember in your high triglyceride, low HDL patient, you're going to have a very large volume or a density of VLDL. And so you need to account to that with the non-HDL calculations. So you have a very elevated LDL or a very elevated non-HDL. You have metabolic syndrome. Again, obesity, elevated triglycerides, hypertension, elevated glucose, insulin resistance, chronic kidney disease, chronic inflammatory disorders, pregnancy associated or premature menopause related issues as well that may predispose you to early onset disease. And then also high risk ethnicity, which is why I showed that, that diagram worldwide. In fact, I see a lot of patients in this region of Indian, South Asian descent, India, Sri Lanka, Nepal, Eastern Pakistan, and they'll tell me, what have I done wrong? And nothing. You're just genetically at increased risk. And then biomarkers, CRP. No, I'm not Paul Worker, but elevated triglycerides, elevated CRP, lipoprotein A, apolipoprotein B, ABIs, those type of things. So there's some things for us to continue to focus on. Now, aspirin, I don't know how Dr. Weigold is, and I welcome him when he talks to kind of speak to this, but for primary prevention, we all know for secondary prevention, patients have to be on antiplatelet therapy, whether aspirin therapy or a second form of antiplatelet therapy. All patients will be on at least monotherapy or sometimes dual antiplatelet therapy in secondary prevention. In primary prevention, it's one of those where the data is just not really as robust. And I think that everyone in the room really knows that. It's one of those where when you start looking at the clinical trials, where in the Ascend trial, you're looking at diabetics, the Arrive trial, you're looking at moderate to high risk, and in a Spree trial, you're looking at older patients. You just didn't really see a significant clinical improvement, especially when you majority of my time training, medical school, residency, and fellowship, and even my early career, we never thought about the bleeding complications. But when you're taking aspirin therapy, you're talking about a 1 to 2% per year risk of significant gastrointestinal distress and bleeding. So when you look at the different guidelines, again, it's one of those used with caution and over 40, again, for the ACC, 40 to 70 for the United States Preventative Task Force, 40 to 60 or 40 to 59. And again, it's that shared decision making in a patient that you think is at elevated risk for heart disease. And within the CAC literature, there may be a little bit better guidance there. But from that standpoint, if you have a patient that you think is at higher risk for having a coronary event and a lower risk for bleeding, that 50-year-old that smokes, that has that 10-year risk of 20%, and, has no history of bleeding and no history of dyspepsia, that may be the right patient for primary prevention. But the 50-year-old on mono, antihypertensive therapy with a 10-year risk of 3% is not going to be the right patient to put on aspirin therapy. So again, it's one of those where LDL reduction. One of the things that this slide's a little bit older is that when you look at the AACE guidelines, actually SIDI is not really mentioned, right? So LDL reduction, it's statins, and in the right patient population, it's PCSK9 inhibitors or bempedoic acid. And then again, in non-LDL reducing therapies like reducing triglycerides, again, fibrates are out, niacin is out, and even omega-3 fatty acids are specified to Vascepa. And then lipoprotein A, we're going to talk about that a little bit more, but obviously that's going to be something very important for us to discuss. So, again, I want to actually not talk about Cydia. It is something that I use, I will continue to use, but, referencing the AACE, it's not really well supported, so I'm not going to really emphasize it. Bempedoic acid, sorry, go back a slide. It's one of those where bempedoic acid, in the AACE, guidance, they did a systematic review. And again, they had 5 to 6 randomized clinical controlled trials with over 17,000 patients. And while they did not see a reduction in all-cause mortality or CV-related mortality, they did comment that bempedoic acid resulted in a small reduction in myocardial infarction, and that for 1,000 patients treated, there were 5 to 15 fewer myocardial infarctions. So there is a potential benefit in a patient. Again, we're going to talk about statins in a second. In a patient who is either statin intolerant, because bempedoic acid does not reduce LDL and the muscle cells. It's only going to be liver. In patients who are either not a goal or statin intolerant, who have coronary disease or cardiovascular disease or at very high risk or high risk for cardiovascular disease, that is the right patient population. One of the things I forgot to mention about the AACE is that they kind of walked back their 2017 recommendation in those higher risk patients to get a goal LDL less than 55. Now that patient with secondary prevention or high likely, that needs that, needs to have that strong reduction, the goal LDL is going to be less than 70 and not less than 55. So as we move on to the next slide, I hit the wrong button, user error. That's 2 strikes for me. 3 strikes, Barb's going to have me out. So I apologize that there's not a pointer here and it kind of things got cut off, but what you'll see is a summation of all the clinical trials on the left, sorry, and then on the right, how they break it down by the different cohorts, right? So in the very top left, you have more statin versus less statin, and then in the bottom, you're going to have, statin versus no statin. And this is going to be the history of secondary prevention and primary preventative cardiology. And overall, you can see that statin therapy is going to be better than non-statin therapy. And some of the trials that really stand out there are going to be, the 4S trial there. And again, the significant reduction in cardiovascular events. Just knowing that those patients there actually had baseline LDLs of approximately 200. And then as you come over here to the right, you can see again a little bit cut off, and I apologize that patients who are both secondary prevention or primary prevention do better with statins. Type 2 diabetics and non-diabetics do better. Type 1 diabetics have so many comorbidities from their glycemic issues and atherosclerotic disease and other complications from other glycemic issues that, they're kind of a mix there. But again, male and female, young, old, and more older or older, hypertension, normal tensive, what have you. Again, in patients across the board outside type 1 diabetics, statin therapies are going to be the best. And then they're going to be really the cornerstone. Again, as we move on to the next slide, Vascepa, and there's a spelling error there, so I apologize. It's a FACCT. What I would say about Vascepa is going to be a concentration of a different of a fish oil, if you would, and is not the traditional omega-3 fatty acids that you're going to get that you're going to be getting off of going to your local drugstore. So with that, in the Reduce It trial, that was associated with a significant reduction in cardiovascular events, and it is strongly recommended in patients who have elevated triglycerides greater than 150. So if you have a patient, again, elevated triglycerides, what to do? It's really difficult, right? And that's one of the things the AACE said. It's really difficult to know what is the right thing to do. But with that, niacin is out, fibrates. There's no clinical benefits. There's no FDA approved combination statin niacin like there may have been in the past. In patients, you want to use Vascepa here, icosapent ethyl, a fatty acid. You want to be using that 2 grams twice daily in patients with known cardiovascular disease or high risk for cardiovascular disease and elevated triglycerides to reduce the risk of cardiovascular events. That to me is something that I need to continue to involve in my practice. It's sometimes insurances and the finances can be a little bit difficult, but that's definitely something that you want to put in your armamentarium. And then again, here is that clinical trial, both when you look at it close and then as you look at it, more expanded out, you can see a separation of the curves and how the therapy actually significantly reduced both the primary endpoint and the secondary endpoint. So again, it's one of those where when you look at a composite of primary versus secondary composites, cardiovascular deaths, all the way coming down, you're seeing that therapy is better. But again, when you look at the AACE guidelines, you'll see that, they recommend this, but they recommend against using traditional, omega-3 fatty acids for the treatment of hypertriglyceridemia and the prevention of cardiovascular disease. So, with that, with PCSK9 inhibitors, always a lot of excitement here. Expensive. The mechanism which this works is that you have the PCSK9 that binds with the LDL particle and then leads to the LDL receptor degradation, leading to a lesser number of LDL receptors. And therefore, you have less clearance of LDL by inhibiting the production of the PCSK9. Then you can actually have more LDL receptors available and dramatically reduce your serum LDL concentration. With that, there are several different therapies out there for PCSK9 inhibition. You have Repatha, Praluent, and Leqvio. What the AACE said is that pretty much at this point, there are ongoing clinical trials for Leqvio, that the wealth of data just isn't there to really give it a recommendation. They treated, Repatha and Praluent the same. With that, when you look at, 17 randomized trials with Repatha and 22 randomized trials with Praluent, Praluent, was associated with a trivial decrease in all-cause mortality and a small reduction in myocardial infarction. Repatha did not have a reduction in all-cause mortality and had a small reduction in myocardial infarction. So the AACE looks at them as having a small reduction. Now, what they would say is in patients able to tolerate a statin who do not have cardiovascular disease or who are not at high risk for cardiovascular disease, you should really not prescribe them. And when you look at their meta-analysis or systematic review, that makes a lot of sense. That really you're talking about for every 1,000 patients, 11 to 18 patients have less events for every 1,000 people being treated at something that may cost $5,000 to $10,000 per year. So just kind of keep that in mind. It can be very powerful, but it kind of underscores what statin therapy can do, not only in just reduction in LDL, but reduction in cardiovascular events. And it reminds me of a patient I saw yesterday who I told him his cardiovascular risk was 9% by the calculator. And he's like, but my LDL is only 109. I said, well, your risk is driven by your age and your hypertension. And I'm interested in reducing your risk for heart disease. He's like, but I don't want to take a statin. I said, I understand. And I greatly appreciate that. And so with that, I will say that I'm not done with my presentation, but I said there's something really good that can help adjudicate. We're going to get that test, and it's going to help make a decision for us about whether or not you need to be on statin therapy or not, and that's going to be the calcium score. So I can't see my slides. I don't know if I did something wrong. So again, you can see here that when you compare it to Vascepa, that when you magnify the separation of the two curves in the cumulative incidence, primary endpoint, secondary endpoint, it looks a little bit more impressive. But again, and you actually blow it up, look at the whole entire study, the actual benefits a little bit less robust. So I think that the discussion of risk enhancers really comes into play when you have questions about should you start statin therapy or should you intensify statin therapy? Now, again, when the AACE looked at, the additional C statistic benefit, it was very marginal. Like apolipoprotein B added nothing. Coronary artery calcium score added the most, but still was quite marginal. And lipoprotein A added some. But what I would say is that as you go down, I don't have a pointer here. This is for suggested PCSK9. But in patients who have known disease, and that could be cardiovascular disease, severe, stroke and carotid atherosclerotic disease, AAA, lower extremity peripheral arterial disease, and they're not getting their LDL to 70, that's a patient that should be considered for a bempedoic acid or a PCSK9 inhibitor. In patients that have a 10-year risk of 7.5 to 20%, those are patients who are going to be started on statin therapy with a goal LDL less than 30 to 50%. If you're uncertain, again, on the intensity, start thinking about, especially if they have a strong family history of cardiovascular disease, aortic valvular disease, they're poor responder to statin therapy to reduce, that's when you should start thinking about pulling in those risk enhancers like lipoprotein A, coronary artery calcium scoring. If a patient is 5 to 7.5% or roughly around those borders and they're unsure, or again, they're 7.5 and to 20% and they don't want to, then that's a good patient for a coronary artery calcium score, because then that will help you make the determination, is this patient? Because what I shared with my patient yesterday is the calculator I used said that without any calcium scoring information, his risk for heart disease in 10 years was 9%. But if he underwent a coronary calcium score and if it was 0, his risk would be reduced from 9% to 3%. So very, very powerful information. So lipoprotein A, it's a mutant, right? It's an LDL-like particle that is genetically driven, that has the same serum levels within 10% all throughout your lifetime. It is pro-inflammatory, it is pro-atherosclerotic, and it's at this point not really modifiable. And I think that people ask, again, why should I check for it? I don't know what I can do for it, and I don't know what the benefit of checking for it is. Again, how would I use it? If I have a patient that has an LDL of 80 and I want them to get less than 70, and all of a sudden I look and their echo shows aortic valve sclerosis, and I look and their lipoprotein A cutoff is 50, is 200. I'm just using an example from the office today. Now, all of a sudden, this is someone that I'm going to be much more aggressive with lipid-lowering therapy, because that lipoprotein A it goes back to that baseball versus that pillow analogy. Lipoprotein A is not modified by your diet. It's nothing but baseballs. It's nothing but, traumatic and pro-inflammatory, and can lead to not just coronary disease, but, valvular disease. And as we go through this a little bit more, it is an independent risk factor for cardiovascular disease, and its potential for development of atherosclerotic disease is actually higher than the traditional LDL particle, but it has a relatively lower predominance within the in the serum and the plasma. And so at this point, we're kind of in that 4S space, right? We need that secondary trial to tell us if we reduce this therapy, will that improve outcomes? So again, I lost my slide. So again, when to screen and when not to screen. Again, lipoprotein A to me makes sense when things don't make sense. So if you have a family history of premature heart disease, mom and dad didn't smoke, dad had a heart attack at 48. That's definitely someone in him and in the offspring. I'd be checking a lipoprotein A. Again, here's the cutoff: 50 milligrams per deciliter. For those that use LabCorp, they use a cutoff of 75, just as an example. So, the 2019 National Lipid Association scientific statement, kind of talked about reasons to do it. Personal history of cardiovascular disease. I don't check lipoprotein A in 90-year-olds, but if you're 50, 60, it's something I'm going to be looking at. Again, severe hyperlipidemia, family history of elevated lipoprotein A, that in-betweener that we talked about, people that you're thinking about intensifying therapies and justifying the expense, a partial response to LDL, progressive recurrent events, calcific aortic valve disease. If you have a patient that has a trileaflic aortic valve with sclerotic degeneration and they're in their 50s and 60s, they almost always are going to have a lipoprotein A elevation. So, okay, there's a couple things here. European guidelines I like. Measure at least once in every adult during their lifetime, right? Remember, all you have to do is check it once, right? As long as you have access to that test result, you're checking blood pressure all the time, hemoglobin A1C all the time, lipids all the time. Lipoprotein A, you're only checking that once. It may vary a little bit, but really within 10%. So if the value is 200, it may be 190, 180, 210, 220, but still it's well above 50. So the 2019 Heart UK consensus statement, again, personal or family history of premature heart disease, elevated, first degree relatives with known disorder, calcific aortic valvular disease. And then with that, being said, there is, when you get a chance to look at some of the data, there is an association with, the Copenhagen Heart Study, where they looked at, almost 10,000 patients, and they found that, people having an elevated level greater than 120 had a fourfold increased relative risk and a 35% higher absolute 10-year risk of myocardial infarction. So, with that, that's something where I think that the cause and effect is there. The question is not the cause and effect. The question is, what is the meaning? What is the benefit of therapies? So, with this, if we can blow this up for people to see it. All right. So, actually, PCSK9 inhibition can lower lipoprotein A levels by 20 to 25%. And they're the only thing that can lower lipoprotein A levels at this moment. Unfortunately, statin therapies are not really going to lower. Maybe there can be some data that actually says maybe a slight increase. Are there clinical specific molecules that are going to be out there in clinical trials? And that's where we really are, right? So, you look at the PCSK9 inhibitors, they're really focused on LDL reduction and, and improving clinical trials. That 20 to 25% reduction in lipoprotein A is really hard to know what that means. Just remember that I try to use that 4S analogy, where again, that was the highest risk of that secondary prevention, where you're talking about baseline LDL of roughly 200, not total cholesterol, but LDL of 200. So here are several ongoing clinical trials. So lipoprotein A is something that will, lead to the development of cardiovascular disease. That linear progression of what levels deliver what quantity of disease, what is that cutoff, that threshold between you're not going to develop disease, what is going to lead to disease, and then as you reduce the levels, what is the reduction in lipoprotein A required on top of other lipid-lowering therapies like statins required to improve clinical outcomes. So just like we did 4S 30 years ago, we're doing 4S now with Horizon, Ocean, Multi-Select, and these are going to be antisense oligotides or small interferon RNAs. They're going to go into the liver and actually block the actual production of these. So these clinical trials, I know like for Ocean that it's actually close to enrollment. We'll see what that data is in the next couple of years. And it should be very, very exciting. One thing I would say before I turn over to Dr. Weigold, and I apologize for how long I've spoken, is oxidized apolipoprotein containing molecules are a surrogate for what can cause atherosclerotic disease. And what you're seeing here is a dose-dependent reduction in the oxidized particles based upon therapies with these lipoprotein A therapies. So I apologize for how long I took.
Thank you very much, Dr. White. That was very good, very comprehensive. Shanna, did you want to discuss something about the chat? I'm not sure, guys, if you're able to put your questions in the chat, we'll be answering those at the end. Perfect. Okay, let's pivot now and move towards Dr. Weigold. Dr. Weigold, we're looking forward to hearing your presentation.
Thank you very much, Barb, and thanks to Shanna and Marty and everyone who put this together. Thanks, Dr. White, for a really great rundown of the data and the presentation of the problem. So what I want to talk about is the cardiac imaging standpoint from the cardiac CT standpoint. See if I can advance the slide here. Okay. So I'm going to touch on two methods of cardiac CT, which are the calcium score and coronary CT angiography. I want to talk just very quickly about the technique and capabilities and limitations of these technologies, and then spend most of the time talking about the clinical utility. So in a standard chest CT, of course, we have an X-ray tube opposite a detector array, which rotate around the patient's body. And as they do so, they collect radiographic data that we can't really look at. It's just a bunch of ones and zeros, but those are then reformatted into images that we can look at. And these are slices through the chest, just like slices of a loaf of bread. But in a standard chest CT, there's no taking into account the movement of the heart. So the heart in the middle of the chest is just this blurry blob with really nothing, not much to look at. I will just say as an aside, even in a standard chest CT, sometimes you can pick out a little bit of the coronary arteries. So what makes a cardiac CT a cardiac CT is the method in which those images are reconstructed. During the cardiac CT technique, while the X-ray tube is rotating around the patient's body and those data are being collected, at the same time, we're running a continuous EKG. And that EKG data are used to timestamp the radiologic data so that then when we go to reconstruct images, we pick out data only using those that were acquired during usually diastole in the cardiac cycle. So we're just picking out the data that were acquired when the heart was standing still. And that method of cardiac reconstruction allows us then to see the coronary arteries with clarity. That's a cardiac reconstruction method, and that's basically what a cardiac CT is. It's a fancy souped-up chest CT. So let's talk for a second about the utility of cardiac calcium scoring. Let's start with a case. It's Monday morning in clinic. We have somebody who shows up as a new patient for a checkup. He's a 58-year-old African-American man. He's healthy, active, no significant past medical history, no medications. He's just concerned about his heart health. because his dad had bypass surgery at age 62, and he's getting up there to close to that age. And then he had a friend who about his age who had a heart attack. So he starts thinking about his heart, and he wants a heart evaluation, and he has questions about medications. He's a non-smoker, his blood pressure's okay, his exam is unremarkable. His total cholesterol is 178. His HDL is not bad, 53. His LDL cholesterol is a little elevated at 120. His creatinine's okay, his A1C is all right. So what do we think about this guy? Are we worried about this guy? Are we not worried about this guy? How do we counsel this guy about his heart, and what do we tell him? So we've got the typical clinical risk factors and methods and tools, and we've got all the data that we need in order to start to try to estimate his cardiovascular risk. So in the old days, we would use the Framingham risk tools. Today, we use the pooled cohort equation. And everybody, I think, is familiar with this. This is an app you can download on your phone, plug in the numbers, and it gives you back the numbers. So we plug in his age, sex, race, blood pressure, cholesterol, diabetes, smoking, hypertension, statin, aspirin, and we get back his 10-year atherosclerotic cardiovascular disease risk of heart disease, whether that's cardiovascular death, heart attack, revascularization, or stroke. And for him, his 10-year risk is about 7.5%. So what do we do now? I think most people are familiar now with the interpretation of this, which says that when you hit about 7.5% is when you want to either strongly recommend or strongly consider using medications and statin therapy in particular to control his cholesterol and start treatment. So he's sitting on the fence right at that about 7.5%. So what do we tell him? As you know, when we start these medications, we're basically committing somebody to pretty much lifelong medication. So it's a decision we don't undertake lightly. And we know that with the data that we have in hand, unfortunately, our risk prediction is not really that great. These clinical risk predictors are really only moderately accurate. So using the multivariate risk prediction based on Framingham data, the area under the curve that we get for prediction of cardiovascular significant events is only about 0.7. So enter the pooled cohort equation, but even that test has its limitations. And if we zoom in here, you see there is, I think, a heavy influence of age, and probably some people argue a disproportionate influence of age in this new pooled cohort equation. This is a graph showing you the predicted 10-year atherosclerotic cardiovascular disease risk that is predicted by the pooled cohort equation on the y-axis. This is non-Hispanic white men. And on the x-axis, you see untreated systolic blood pressure. All the other variables are to derive these lines are using the average mean values for things like blood pressure, et cetera. Okay, I mean, not blood pressure, but cholesterol, diabetes, et cetera. And what you can see is at the bottom of the graph, that kind of light brown line is the group that is age 40. No matter what their blood pressure runs, whether their systolic blood pressure is 90 up to 200, if they're that young, they never hit the 7.5% 10-year ASCVD risk. But patients who are 80, and the line below that is patients who are 70, always hit that line, even if their blood pressure systolic untreated is 90 to 100. So there is a heavy influence of age. And so this is one of the limitations of the clinical risk predictors. Here's another example of limitation. This is in patients who have diabetes. And on the left, it's patients with diabetes without hypertension. And on the right, patients with hypertension. Again, it's on the y-axis, 10-year ASCVD risk. And the different lines represent different ethnic groups and sexes. And what you can see is that in patients who are diabetic, almost all of them, once they hit above about age 55 or 60, they hit the 7.5% threshold for starting statin therapy. So there are certain clinical risk predictors that heavily influence the pooled cohort equation. Enter coronary calcium score. So this is a technique that was developed quite a while ago, back in the 90s, and very simple, straightforward technique, simply a CT scan of the chest with some form of ECG gating that allows us to visualize the coronary arteries in detail and identify calcification and apply a scoring system that was developed and derive from that a rough measure of the burden of calcium seen in the coronary arteries. Very early on, it was realized that this technology can help to risk stratify patients into lower and higher risk groups. So on the left at the top, what you see is if you look at the column that says CACS, that's the coronary artery calcium score, and dividing the patients in this study into 4 groups. Those are the calcium score between 1 and 100 and 1 and 100. Second is 100 to 400, 400 to 999, and the last group is those with a score of 1,000 or greater. The next category, the next column over shows you the relative risk of the events here, which is coronary heart disease death or myocardial infarction. And this is comparing to patients with a calcium score of 0. So those with a calcium score under 100 already had an increased relative risk. You can see the confidence interval already actually is falling outside of 1, but the p-value doesn't quite hit statistical significance. But those with a calcium score of 100 or greater had progressively increasing relative risk of coronary heart disease or myocardial infarction and reached statistical significance. And on the right, you see the plot that sort of demonstrates the same data just in a plot fashion. So very early on, it was recognized that higher coronary artery calcium scores are associated with a higher event rate of death, cardiovascular disease death, or MI, and higher relative risk ratios. Those in the high risk rate had a calcium score between 400 and 1,000, and their rate was 4.6% after 3 to 5 years. And those with calcium scores above 1,000 had a very high risk rate of 7.1% at 3 to 5 years. Now, interestingly, that's just taking calcium score by itself. Interestingly, in subsequent studies that looked at this, what was found was that even on top of the traditional clinical risk factors, calcium score could add additional discriminatory power. So this was the St. Francis Heart Study, a prospective study of almost 5,000 asymptomatic men and women aged 50 to 70 with about 4 years of follow-up with a total event rate of about 120, a number of events of about 120. And on the left, you see the coronary calcium score and all coronary disease events. And the score, again, broken down into those 4 groups, 0, 1 to 100, 100 to 400, and greater than 400. You see the number in each category. You see the event rate in each category and the relative risk in the column on the far right. Those with a score between about 1 and 100 had a relative risk ratio of about 2, but the confidence interval spans 1. Those with a score of 100 or greater had a much higher relative risk ratio and achieved statistical significance with confidence intervals that were outside of that 1 range. But if you look at the graph on the right, this is now on the y-axis, what you have is the percent per year of observed events. That's, again, coronary heart disease death, myocardial infarction, revascularization, or stroke. And this is on the x-axis, predicted 10-year risk based on Framingham risk. So Framingham, the far left group those are the Framingham risk less than 10% over 10 years. And you can see that no matter what their calcium score was, whether they were first, second, or third tertile of calcium score, their observed percent per year rate was actually less than 10% per 10 years. And on the far right, you see that for most of the people in most of the calcium score groups, their observed event rate was greater than 2% per year. In other words, 20% per 10 years. But in the middle group, in those who had a Framingham risk score that was between 10 and 20%, the intermediate risk group, there was a divergence in kind of a spread of observed event rates. Those who had a calcium score that was in the first tertile, the very lowest level of coronary calcium, had very, very low event rates that were less than 0.5% per year. In other words, less than 5% per 10 years. And those that were in the highest tertile of calcium score had an observed event rate over 2% per year. In other words, 20% over 10 years, which is basically high Framingham risk. So even though Framingham predicted that they would be intermediate risk, if they had a lot of coronary calcium, the observed event rate was actually quite high and put them in the highest risk category. A subsequent study that pooled data from 4 different studies found, again, similar results. This is just intermediate Framingham risk patients only. And again, those who had the lowest tertile of calcium score had a low event rate that actually puts them in the low Framingham risk group. Those that had the highest tertile of calcium score over 400 actually suffered event rates that were equivalent to those that Framingham would have considered higher risk patients. So coronary artery calcium is a very powerful discriminator within coronary heart disease risk stratification. This is another study now with a very large number of patients, 44,000 asymptomatic adults referred for CAD screening. And here, the sensitivity is even a little higher. The 3 lines here represent patients who have a calcium score of 0 in yellow, a calcium score anything between 1 and 10, and a calcium score greater than 10. That's the group that is spreading out with the event rates that are higher in this survival curve. Now, granted, the y-axis you can see is kind of zoomed in. We're just looking at between 0.9 and 1. But this is follow-up over about 12 to 13 years. And you can see that those with even relatively modest calcium scores demonstrate a significant difference in their overall event rates. The discriminatory power of coronary calcium score continues in diabetic patients and non-diabetic patients. So this is a different study with 10,000 asymptomatic men and women and patients who are diabetic either with oral therapy or on insulin, but most of them are on oral therapy. On the left, you see clinical characteristics of these patients divided into the diabetic and non-diabetic group. You can see that there are some differences, statistically significant differences in age, prevalence of hypertension. And as you would expect, on the right, the cumulative survival in the diabetic patients is lower than in the non-diabetic patients. This is after about 4.5 years of follow-up. Again, the y-axis is sort of zoomed in, but we do have a statistically significant difference in survival between those 2 groups. Okay, so diabetics fare more poorly. That's not new. What is interesting is that if you look then at the calcium score in these 2 groups, even in the non-diabetic patients, when the calcium score is exceedingly high, you see a much lower cumulative survival in those patients. And in the diabetic patients, again, Overall survival is lower, but again, the calcium score, even on top of that, further risk stratifies the patients, and we see the separation of the curves in survival. On the other hand, the complete absence of calcium is an excellent prognostic finding. So patients who have a calcium score of 0, whether diabetic or not, had very, very good prognosis with excellent survival after 4 years. This is now from the MESA study, a longitudinal population-based study of 6,800 men and women in the US, 45 to 85, without cardiovascular disease. And this study looked at about 5,000 patients not already taking a statin, under 75 years of age, with an LDL above 70. So according to the ACC guidelines, again, if you calculate their 10-year ASCVD risk from the pooled cohort equation, those that have a greater than 7.5% 10-year risk are considered what we call statin eligible. Patients who you really, the guidelines right now kind of recommend treating with statin therapy. So this study in particular had 77% statin eligible patients using those criteria. On the left, what you see is 3 groups of patients. On the left side, the bar there is patients in whom statins should be recommended. In other words, you calculate their 10-year ASCVD risk, and it's above 7.5%. In the middle bar is patients in whom you should, the guidelines would say to consider statins. Those who have a little bit lower 10-year risk, about 5 to 7.5%. And the bar on the right is the patients who are at the very, very lowest risk, less than 5% 10-year ASCVD risk. They are patients in whom you would say statins should really not be recommended. The bar graphs show the distribution of calcium in the 3 groups. The blue represents everybody with a calcium score of 0. The red or orange is those with a mild degree of calcium between 1 and 100. And the gray is those with a calcium score greater than 100. And it's just interesting to see that on for example, the far left bar, in patients in whom statins are recommended, 41% of the patients have no coronary calcium. And on the far right, patients in whom statins are not recommended, you still have about 20% of patients who have some degree of coronary calcium. And on the right, it's very, very small, kind of hard to see, but this is on the left side, men, and on the right side, women. And what we're looking at is event-free survival. These are survival curves across the 3 groups. And what we see is that in patients in whom statins are not recommended, for example, in the middle, those who have the highest degree of coronary calcium or calcium greater than 100, you still saw separation of the curves. And in patients in whom statins were to be recommended, the blue line at the top, that's calcium score of 0, they still fare better than patients with other degrees of coronary calcium. Now, this is kind of a terrible slide because there's way too many numbers here. But this is numbers and data that are showing that, again, similar sort of message, statin recommended, statin considered, or statin not recommended on the left. And if you kind of just look to the hazard ratio column in the ASCVD group, you can see that hazard ratios for patients in whom either statin recommended or considered or not recommended, there's differences in the different groups. In particular, in patients in whom statins are not recommended, the hazard ratio for patients with any calcium score present, I wish I could point to it, but the bottom, the hazard ratio is 1.7, but it spans 1 in that group. But let me go to a different slide to kind of look at this a different way. So this is ASCVD rates in the non-diabetic group, patients with a 10-year ASCVD risk greater than 7.5%. Greater than 7.5%. So you can see at the bottom group, it's 7.5 to 10. The next group over is 10 to 15, 15 to 20, and greater than 20%. And again, the bars represent those with a calcium score of 0 in blue. Those are the calcium score between 1 and 100 in orange. And those are the calcium score greater than 100 in gray. So for patients who have a predicted 7.5 to 10% risk, you can see that the actual observed rate in patients who have a calcium score that's greater than 100 starts to get up toward that 7.5% rate. On the other hand, patients who have a risk that's between 15 and 20%, for example, in the third group, but have a calcium score of 0, the blue bar there shows you the observed rate that's only 4.4%. So again, just reiterating the same message that the calcium score helps us to differentiate the patients. So kind of central illustration, bottom line regarding how to think about using calcium score in asymptomatic patients when we're trying to risk stratify. The take-home message here is start with the pooled cohort equation, start with calculating the 10-year ASCVD risk. In patients in whom on the far left here, the calculated 10-year risk is less than 5%. In this study, that was about 1,800 patients. And if you looked at that group and found those with a calcium score of 0, which was most of them, about 80%, the observed event rate is about 1.3 per 1,000 patients, a very, very low observed event rate. But even in that same group, when there is actually coronary calcium and some degree of coronary artery atherosclerosis present, the observed event rate is still very low at only 2.7 per 1,000. On the other hand, if you go to the far right of this picture, this image, those in whom they have a 10-year calculated rate of greater than 20%, the highest risk group, even in those with a calcium score of 0, you still saw a relatively high 11.7 per 1,000 event rate. And that puts them above that 7.5% event rate. So at the two extremes of these populations, the calcium score actually is probably not helpful. So if you have a patient with a less than 5% calculated risk, their risk is super low. You don't even need to do a calcium score in most of these patients. And similarly, if their calculated risk is above 20%, they need everything thrown at them to risk stratify and to treat them. But in the middle group, those between 5 and 7.5 and 7.5 up to 20%, when the calcium score is 0, the event rate is actually pretty darn low. And so, you know, you might have room to kind of and time to work with the patient and decide about statin therapy or not if their calcium score is 0. But if they have calcium present, especially if they're in that 7.5 to 20%, and they have almost any degree of coronary calcium, you should strongly consider statin therapy in these patients. So this is where calcium score is the most useful, is in this middle risk group. This graphic basically says the same thing. In the middle risk group, if you find a calcium score of 0, you may not have to necessarily treat them, at least not right away. The way I approach this is to talk to the patient and talk about diet and other interventions that we could try. I think still most cardiologists would say the goal is still to try to get the LDL cholesterol down below 100, since that's the general recommendation. But, you know, if they're at 110, 115, you know, you have some room to work with them if you've got a relatively young patient before you commit them to lifelong medical therapy. So back to our patient. His calculated risk is at about 7.5%. So this is the perfect patient in whom to get a coronary calcium score to further risk stratify the patient. So we did that for him. And this is what we got. His calcium score is 112. He's got obvious coronary calcium and subclinical coronary atherosclerosis present in the proximal LAD, in proximal segments of the RCA. This is a patient for whom I would say this is a complete total no-brainer. He definitely, absolutely should be on statin therapy. We should be trying to drive his LDL down, definitely below 100. I would say the lower the better. Um, and probably consider also even a low-dose baby aspirin for this patient. Asymptomatic, otherwise healthy guy, but the calcium score here has revealed that he's got um, significant coronary artery calcium, and he should be treated, moderately aggressively to try to get his LDL under control. He's got a long way to go before he gets to his 90s, and I think he should clearly be treated. So in his case, the calcium score here has really helped to guide therapy. And if his calcium score was 0, I think it would be completely the opposite picture. I would talk to him about what we could do with diet and other interventions to try to help him out. Okay. So to sum, clinical risk scores are a good start, but definitely incomplete. There's a wide range of observed risk within the especially intermediate risk category. Risk can be further differentiated by the presence and extent of calcium. Consider using this test when the 10-year risk is between 5 and 20. A calcium score of 0 confers an excellent prognosis. This is just a little breather slide to allow us to take a minute to just catch our breath and look at some flowers. All right, I've got about 10 slides to talk about coronary CTA, so this should be quick. I know it's getting late. Coronary artery CT angiography. Can we zoom in on that a little bit? Beautiful pictures, lovely pictures of the heart. Just, really fun to show off. They're like netograms. They allow us to look inside the coronary arteries and see plaque that we can't otherwise see without an invasive coronary angiogram. Really great test. Okay, it's not for everybody. If you have a really obese patient with a BMI above 45, pictures start to get pretty grainy when you get to that level of body size. So, I'll never tell you not to get a coronary CT angiogram, but just, understand the pictures here are going to be a little grainy. If it's normal in this patient, for example, a young patient who's obese, but they have normal coronary arteries, we can still usually say that even if their body mass index is really high. But if they have any degree of calcium or plaque present, it starts to get real tough to know whether or not there's any obstructive disease or not. Their heart rate and rhythm definitely play a part because, again, this is an ECG-gated CT scan. So if their heart rate is real fast and they're irregular, whether that's AFib or a lot of PVCs or PACs, starts to get pretty blurry. It gets hard to tell what we're looking at. If they can't lie flat with their arms above their head and hold their breath for 20 seconds, it's going to be a little bit of a rough study, so watch out. If they can't get contrast, well, we need contrast, so that's kind of a no-go. Again, just as a caveat, as an aside, there's no such thing as an iodine allergy. Nobody's allergic to the iodine atomic element of iodine. But there is certainly contrast allergies. So people who have a shellfish allergy do not necessarily have a contrast allergy. That's an old myth. Ask about contrast allergy in specific, not just shellfish allergy. If somebody has a contrast allergy, you can use the dye prep. The standard is the Greenberger regimen, 50 milligrams of prednisone or 60 afternoon before, night before, and morning of, and 50 or 25 of Benadryl the morning of. What about patients that have been previously revascularized, whether with stents or bypass grafts? Well, really, coronary CTA is best used in patients with chest pain without known coronary disease. So patients who have that scenario or patients who have an abnormal echo with unexplained LV dysfunction or abnormality and are not previously revascularized, patients who have an abnormal but non-severe stress test, and not previously revascularized, really this is where the sweet spot for coronary CTA. In patients who have prior coronary bypass, the utility becomes a little bit more limited. The bypass grafts can be well visualized. So if that's your question, are the bypass grafts open or not? We can answer that question very easily. But the native arteries are likely to be heavily calcified and much more difficult to evaluate. Patients who have had prior stents, if they've got one big, large caliber stent or two in proximal segments of the arteries, we can usually see through those stents. If they have multiple stents that are small in caliber in distal branches or side branches, that gets a little bit more difficult to evaluate. So let me just quickly run through the evaluation of the chest pain patient, and we are trying to identify causative obstructive flow-limiting stenosis and identify patients who are candidates for revascularization. Coronary CTA does a great job of this. You don't even have to know anything about coronary CTA to know we have a problem in this right coronary artery. It's a pretty ugly looking vessel. There's a lot of calcium and plaque and a pinch point in the middle of the vessel. And the invasive coronary angiogram demonstrates the same. Now notice how ugly that proximal segment looks. And though on the invasive angiogram, you see there's disease and a lot of lumpy, bumpy stuff, but actually no stenosis. So there's a little bit of an art to reading around all of that calcium. And that's, why it takes a little bit of experience to read these things. This is a plumbing problem. We identified the plumbing problem. The patient needs revascularization. Now, on the other hand, there can be an added bonus by doing coronary CTA in your chest pain patients. If you identify this picture in your chest pain patient, that's a really great result. No coronary atherosclerosis in the vessels of this patient. And you got about a 5-year warranty on this if you find no atherosclerosis in any of the coronary arteries. So it's actually really helpful also to identify this scenario, no disease, no atherosclerosis. You can take that to the bank for quite a while. Their chest pain's not coming from their heart. The third group, a little bonus again, patients who have chest pain and you don't identify out and out obstructive coronary disease, but you do identify non-obstructive coronary atherosclerosis. Some of these patients may not have been aware that they're carrying around subclinical coronary artery disease and are not on treatment. If I could point at this is the left main branching into the LAD going north and the circumflex going south. And you can see starting in the left main, in the distal left main, all the way through the proximal LAD, there's kind of this rind of gray material with a couple calcified spots in it. All of that is atherosclerotic plaque. And actually, this particular patient has what has been shown to be the high-risk features of patients who subsequently develop myocardial infarction right in this location. This is a plaque that's waiting to rupture and occlude the artery with acute thrombosis. So this patient who has this finding, if they're not on statins and aspirin, should be soaked with medication in order to turn this non-calcified plaque into stable calcified atherosclerosis. And the coronary angiogram in this patient, because they still had chest pain, demonstrates, there's no real pinch point. You could maybe argue in that diagonal branch there's a stenosis, but in that LAD main vessel, you do not see obstructive flow limiting disease, but they have a serious problem that needs intensive medical therapy. And a stress test will not find this because there's no obstructive disease in the LAD proper. Similarly, in another patient in the right coronary artery, this is non-flow limiting narrowing, but they have the disease process, and a stress test won't find this. It's going to be normal. And potentially you might miss an opportunity to identify early coronary atherosclerosis. So this is just added bonus features of coronary CT angio to be used in chest pain patients, either to try to identify a real plumbing problem with a high risk, high flow limiting stenosis that you can revascularize, or as an added feature finding nothing, or as a bonus finding early disease that now you know about and can start to treat. Here's the angiogram for that patient. No significant stenosis. So to sum up, cardiac scoring is a screening exam. Now, these days, it's covered by most insurances, dependent on and deductible and co-insurance that are met by the patient, dependent on medical necessity and family history provided by the referring physician. The team at Adventist Health will obtain eligibility and do a verification check with appropriate insurance. If insurance denies due to medical necessity and provider requires patient to get this scan done, it can always still be done if the patient is willing to pay for it out of pocket. It's not that expensive. It's under $150 for a calcium score. I think it's well worth it in the appropriate patient. It's a wealth of information that can be extremely useful. And there I'll stop. Thanks very much.
Hey, thank you both so much. That was great. We do have some questions in the chat. Dr. Weigold, I'm going to start with your questions and then because you just finished. So one question we have is, should every patient, male greater than 40 and female greater than 50, get CAC, primary intervention strategy?
Good question. I've thought about just doing that myself. I still think that at the end of the day, we don't want to completely throw away the clinical risk predictors. So I would still start with the pooled cohort equation, still start with calculating their 10-year ASCVD risk using that calculator. It's an app that's available on everybody's phone. You can't see my phone because it's blurred, but just get the app. It's easy enough, plug in the numbers and calculate their risk. If it's less than 5%, I think they're okay. They're very low risk. But if they're, especially 7.5 or higher and in that intermediate risk group, then sure, fire away, go ahead, get the calcium score and see what you get.
Great. Here's another question. Can you talk about CAC in patients with stents in place?
Not useful. Once they've got a stent and once they've got known established coronary artery disease, they're past the calcium score world. They don't need it anymore.
What validated imaging is available to assess coronary vascular information?
I'm not quite sure of the
Dr. Weigold, I think the question may be vascular inflammation.
Oh,
not much. Some people have looked at cardiac PET as a way to try to do that. It's just technically a very difficult study to do. There's not robust data for it at this stage.
the last question for you, Dr. Weigold. What do you say to those who advocate for statins for everyone, regardless of their risks, as a routine prevention? And are there any side effects to that?
Yeah, there are side effects of statins. I mean, it's a safe medication with a good side effect profile, but not a zero side effect profile. And I think treating just everybody would definitely be overtreatment.
Great. And one more question came in. How about CTA with FFR?
So FFR, fractional flow reserve, is a technology that originally started in the cath lab via invasive procedure and flow wire. There is a CT non-invasive, purely imaging form of that. It requires special software. So different institutions may have that available. We don't have that yet at Adventist. That may be something we get in the future. It is helpful in patients in whom you do a coronary CT angiogram and the result comes back intermediate, meaning intermediate degree of stenosis, physiologic significance is uncertain. In those cases, CT-FFR may be helpful. That's the minority of patients. In most patients, just the CT angiogram alone will tell you the answer, but in some patients, it's helpful.
Great. Okay, Dr. White. So, Dr. White, I'm going to mispronounce this medication, but why not use ezetimibe as an adjunct to a statin et cetera, to get the LDL less than 55 in high-risk patients?
Yeah, I think that's a great question. Hopefully my talk wasn't taken to say don't do it. Relatively, I was just trying to reference, um, the AACE that used the Zetia ezetimibe combination with statin therapy and the Improve It trial from, way, to 5-10 years ago in the 2017 guidance that did recommend, because that's where the LDL reduction goal 55 comes from, is that combination therapy with Zetia or ezetimibe. And I was a little bit taken aback that in the language of the updated 2025 AACE recommendations that they have kind of walked back that, and they didn't really address the use of ezetimibe really at all. So I think that in my practice, I have, going back to some of the things that Dr. Weigold talked about, is I have not abandoned, or I don't plan to abandon the use of ezetimibe. I think that it is a potent drug to augment LDL reduction. I just, using a reference, couldn't say that the reference that said go to less than 55 still says go less than 55. But if I have a patient who I determine needs a 50% LDL reduction for primary prevention, or needs an LDL less than 70 and they're significantly above, I would still strongly consider it. I think that Dr. Weigold's comment about side effects, that bempedoic acid is new to the market, it definitely has some side effects, tendon issues, cholelithiasis, et cetera, that need to be well described to patients. Ezetimibe has essentially 15, 20 years of clinical data, and it may have a modest improvement in cardiovascular events, but at the same time, pretty well tolerated, safe, and financially affordable. So I'm not asking people to not use it. I was just trying to reference more updated guidelines.
Another question: what is the role of lipo B? Excuse me.
Yeah, I mentioned that a little bit. Apolipoprotein B is a component of LDL and VLDL. So you kind of already have that information. And, Dr. Weigold and I both talked about that C statistic that, and again, the closer to one, the better that test is to tell you, whether or not something's beneficial. And he used the value of 0.7, and I reference, 0.69 to 0.8 something, depending upon which pool cohort equation that is leveraged. Of all the three that, as far as modifying factors that the AAC looked at, that one really performed the worst. And I believe that it just doesn't add new information to the equation. You already have the LDL in your determination. I think that, lipoprotein A is a pro-atherogenic, pro-inflammatory molecule. You want to know that. And what Dr. Weigold just did was talk about the discriminative power of coronary artery calcium. I was a little bit surprised by the reported C statistic. I use coronary artery calcium quite a bit. I love the question, coronary calcium for everybody. I think that's a great question. I do use it quite a bit, actually. I won't say everyone, but a lot of people. And I do agree with Dr. Weigold's comments that, statins shouldn't be for everyone. There's cost, there's risk, there's side effects, there's people at low risk. And the thing I want to underscore with his comments is that when you adjudicate someone with either a pool cohort equation to have low risk, or with calcium scoring to low risk, you're saving them the time, money, and expense, and the risk of side effects. I think as providers, a lot of us will run into situations where patients, like the one I referenced, don't want to be on statins. I don't know what Dr. Weigold's experience is, but I have a statin discontinuation rate of 20%. So with that, I try to be cautious about when I prescribe or increase intensity in statin therapies.
Great. Dr. White, one last question. I think you mentioned it in your presentation, but I think a little more clarification. Even though Lp(a) is genetically determined, what are the best ways to decrease levels if possible?
Await for the results of the Horizon and Ocean trial. I mean, again, you can reduce your serum cholesterol by reducing your saturated fats and reducing your serum cholesterol intake, exercise, keeping the carbohydrates, keeping the calories. there's a lot that you can modify your diet, and reduction of, improving your diet, reduction of serum cholesterol by diet alone can significantly improve outcomes. Since a lipoprotein A is genetically driven and is not modified by your diet, it's autonomous, and there's nothing that you really can do. However, if it's present and, again, you have premature heart disease, a family history of premature heart disease, at this point, you can go more aggressively at the LDL reduction. And then as we go forward in the discussion that I gave, we'll better know with trials like Horizons and Ocean if, lipoprotein A reduction improves outcomes, and, what is that net benefit? Is it a small reduction or is it a large reduction? Is it a 4S reduction, or is it a Fourier or an Odyssey reduction? So more to be told. I think there will be a proportionality. People with very high lipoprotein A over 180, I think in secondary prevention, they're the ones that are going to gain the most benefit.
Great. I think that's all of our questions for this evening. I was going to wrap us up tonight. I wanted to thank our expert panel of physicians for giving those fantastic presentations. And the nice thing is we can get our best heart care right here in our community of Montgomery County. I'd like to extend my thanks to those who have joined tonight, and thanks for taking the time. We know your time's valuable, and we really are grateful to you that you spent the evening learning new options for heart care. I want to make sure you guys take our survey to be able to get your CME credit as well. And that should be shown here in a minute, I think. There's a QR code. There we go. And I just want to thank everybody tonight, and have a wonderful rest of your evening.
Thank you, Barb. Thanks, everyone.
Thank you, everyone.
You're welcome.